start my recording here. So, did they tell you about Panopto? If you go on to Angel, there's a area that's called Panopto Re-Recordings, and I audio tape and videotape all of my recordings, so you can go back and listen to them again if you're sick. Something you don't want to listen.
We always listen.
Dana.
I just have a quick question. Do we have to have our flu shot for
In a while, not yet.
Okay.
I don't think the current flu shots that are out there are fully updated yet.
Okay.
Usually it's by November 1st,
Okay.
but I will let you know specifically more as we go along. But yes, you will eventually.
Okay.
I'm sorry?
No, what you have
You have to get it. Or you don't go to clinical. You don't pass the course. That's not my choice. That's college policy. Okay, two components that we look whenever we look at an arterial blood gas analysis. One being acid-base balance and ventilation, which is primarily looking at the PCO2 bicarb relationship as reflected by the pH. Base excess we haven't really talked much about. We'll spend a little more time at a later point in time. But base excess trends right along with bicarbonate. So as bicarbonate becomes excessive, the amount of base, because bicarbonate is a base, goes up also. There's other factors involved with it. One of the major ones is the level of hemoglobin that you end up having. We also will find as we go along how electrolytes, specifically potassium, can have an effect on the acid-base balance. And when we talk about the function of the kidney in its relation to acid-base disturbances, we'll come back and visit that one. And then there's all these factors related to oxygenation, both the dissolved component, that which is attached to the hemoglobin, whether there's abnormal species of hemoglobin present, all those things are going to affect it. And we know there's all kind of indices we can use to evaluate whether or not a given PO2 is okay. So if I told you the PaO2 is 85, what do you think? Thank you, yes. If it's 85 on room air, okay. If it's 85 on 100%, totally different picture. Okay, so you need to take both of them into account. The primary respiratory index that we utilize to be able to evaluate acid-base balance, obviously, is the PCO2. The definition of a blood gas is anytime you have a gas that is dissolved into the blood, creating a partial pressure. That's what we're being able to monitor. Notice that it is a hyphenated word, technically. No one utilizes it. But we can either analyze it for pH, PCO2, and PO2 and calculate the bicarbonate from there, and that's what a blood gas analyzer does. And we can also put it through a CO oximeter, a separate mechanism, using a spectrophotometric method to be able to evaluate the different species of hemoglobin and the total hemoglobin present. So sometimes it's one machine that does both. Sometimes it's two separate machines that you have to run it through. And a lot of hospitals are now going to point-of-care testing. They're foregoing the saturation and focusing instead just on the pH, PCO2, and PO2, as well as typically some electrolyte measurement in the process. And here's one that incorporates both of them together. It's a kind of old slides, but you get the gist of it. As far as measured versus derived, in the case of a blood gas analyzer, there's three primary electrodes that you should be aware of. The Clark, which measures PO2, the Severing-House, which measures PCO2, and a modified Severing-House called the Sands electrode, which measures pH. All the rest of those other values there on the bottom are derived values. In other words, there's not a mechanism by which bicarbonate is directly measured. Rather, the pH is measured, the PCO2 is measured, and from the wonderful Henderson-Hasselbalch equation, we back figure what the bicarb is. Normal values. The only one, again, we probably haven't encountered yet is the bicarbonate, the base excess, and a normal value for that is plus or minus 2 milliequivalents per liter. But all the rest of them should be values which you've seen 1,001 times, and there's no confusion there. Yes.
Plus or minus what?
Plus or minus 2. So in other words, the normal value goes from -2 to +2
Okay.
milliequivalents per liter. Hemoglobin saturation should total, if you take a look at all the various components, it should total up to about 100%. So if I got a situation where my arterial saturation is being reported as 97% and the carboxyhemoglobin is being reported as 50%, that's an impossibility. It can't total up there. 3 other areas of information that are necessary, and we'll go through these individually, but about what does the patient look like? You need to have that information to truly assess what's going on with the blood gas. Sometimes you need additional lab data, and when we get to metabolic acidemias, we'll find that we need to calculate out a anion gap to know what's truly going on. And then also through patient assessment, there's some clinical information that we can pick up. So the immediate environment might be things like FiO2. If they're on a nasal cannula, I expect a higher PaO2 than if they're on room air. If they're being measured in Denver, it's going to be a different value that you're going to assess. And really the presence of normality will be interpreted differently. Whether if I got someone who's coming in from a house fire, I'm going to anticipate having a higher level of carbon to carbon monoxide. To what extent the patient is conscious. Some other environmental information. If I had a bottle of Jack Daniels that was 3/4 gone and some Quaaludes sitting by the bedside, the anticipation might be that I had a patient who was an overdose patient in the process. Some other lab data, again, that we'll have to assess that might be important in putting the whole picture together as far as how that blood gas is showing up. And then also looking at, again, things like their respiratory rate, their minute ventilation, other patient assessment tools, so that we end up determining that perhaps, oh, this guy's got COPD. It's going to change how that blood gas is interpreted. What we're doing up to this point in time has been really just classification. All we've done is just say, what's the acid-base status? What's the oxygenation status? Is there any compensation going on? So all we've said is it's fully compensated metabolic alkalosis with mild hypoxemia. What we really want to go further is getting into some calculations. Yeah, they do. To be able to say, is this the predicted amount that is going on? First of all, there is never anything such as overcompensation. The body doesn't know how to overcompensate. If you're looking at something that appears to be overcompensated, it's probably a second primary disorder going on simultaneously to the one that we think is going on. Okay. You can also have a situation where there is a lack of compensation present. So for instance, if I have a metabolic acidemia, what would you expect to see as far as the PCO2? It should be decreased. What if the patient happens to be on a ventilator and is paralyzed? Well, that compensatory mechanism can't kick in, right? So you end up having something going on there. Could also be that the compensatory organ, in this case the lungs, patient's got COPD. So he's got an underlying metabolic acidemia, but he can't increase the alveolar minute ventilation to compensate for it. Could be that there's not enough time. So that's what we typically see in a renal. When the kidneys are the compensatory mechanism, they don't respond as quickly. They take a couple of days to fully kick into gear, to start retaining bicarbonate. And then the other one that we'll encounter is a primary disorder that's present but working in the same direction. So I have a metabolic problem and a respiratory problem, but it's hard to sort out which is which. This is blown up for you at some point. We'll come back and visit this quite a while down the road. But kind of everything we've learned to this point in time is just assuming there's a single disorder that's present. That's rarely the case, to be honest with you. If you think about patients in the hospital, they're never nice and clean like that. You always got something else going on. And what this is showing is that if I have a primary respiratory acidosis that's of an acute nature, For every 10 torr rise in PCO2, the pH is going to drop by 0.08, and the bicarbonate will rise by 1 milliequivalent per liter. Now, I will tell you there will be some questions on tests that utilize this chart. I will provide the chart with you so you don't have to memorize it. Okay? And if it's a metabolic problem, you can see there's a change in bicarbonate now that we're assessing, how that affects the pH in the PCO2 levels. And using these predicted equations, we can get it to within a very narrow pH range to what the actual value is and what the actual PCO2 is. So here's an example. 17-year-old female involved in a motor vehicle accident. Okay? Blood gas shows 7.24, PCO2 of 60. Where's my bicarbonate? You don't need one. I know that for every change in CO2 from a normal value of 40 is that there's a 20 torr change. For every 10 torr, there's a 0.08. So because I now have 20 torr, it's 0.08 times 2, or 0.16. So the anticipated pH just from the CO2 is that there is 7.24. My measured value is 7.24. Everything is accountable simply because of the PCO2 rising, okay, in the acute situation. So what is the bicarbonate? It actually calculates out to be 26. And I'll explain why you see an elevation in bicarbonate at another point in time. Another example, 32-year-old female complaining of dyspnea. Her ABGs in the ER show these values. Again, we would classically call this a respiratory alkalosis that's fully compensated. Again, going back, it's got to be a chronic. How do I know it's got to be a chronic problem? The bicarb is compensating. So that has to have been going on for at least a couple of days. So my predicted pH here would be 7.44 plus 0.066, and how I derived it, that was going back to that chart looking at the chronic change for every 10 torr rise in PCO2, how much you change the bicarbonate. And in this case, the predicted pH, 7.47, is close to, but doesn't quite get back to the 7.44. So it must mean that there's something else going on. Our projected bicarbonate would be 24 minus the 11, or 13. So there is some other underlying metabolic disturbance present. If this gets a little bit confusing, it's okay. We'll walk through it again later on. But basically, it allows us the ability to look at a blood gas and say, everything that is explained is not explained. That pH doesn't explain the situation we have. There's something else going on with this patient. Okay? And we'll end up finding out that in this case there's actually a superimposed metabolic acidosis on top of the respiratory alkalosis. So even though the respiratory alkalosis is there and the metabolic acidemia is compensating to try and return the pH to normal, over and above that, it's compensating further than you would expect it to. So there's got to be something else going on. And this is where it gets really, really subtle, and some of the changes that you don't pick up on ordinarily. We've gotten to the point now we just look at a blood gas. Oh, I know what that is. Do ya? Takes a little bit more time. As far as oxygenation is concerned, again, we're going to look at the FiO2, the barometric pressure, and to some extent the age. We know that based upon Dalton's law, the percentage of the gas will tell us what the partial pressure that is present for that specific gas. And the sum of all the partial pressure should add up to what the barometric pressure is. And again, the values that are present do not change depending upon altitude. So FiO2 on Mount Everest is still 20.95%. Doesn't vary as we go. And if we're talking about a dry gas versus an inspired gas, once you have that inspired component, you see the little I, you know that you have to account for water vapor in some fashion. So we're going to subtract that water vapor from the barometric pressure prior to multiplying it by the concentration. And this is just, again, going back for dry gases, accounting for each of the constituents of the atmosphere, including argon. And just showing that as you rise in barometric pressure from a sea level at 760, you have a fall in barometric pressure So when you're in Denver, if you have barometric pressure is 640, that's going to mean that the partial pressure in the air is significantly less than you would have at sea level. Drop in barometric pressure, drop in inspired PaO2, drop in alveolar, which ultimately means a drop in arterial. So how do I adapt? Well, in a lot of cases, especially if you're flying, we pressurize the cabin. Now, it's not pressurized to what would be considered normal, and that's why when you fly, you still feel a little bit lightheaded, and you might become a little bit tachypnic and tachycardic, simply because there is a reduction in oxygenation. And if we ever got to the point where we would lose barometric pressure, that's where those little masks appear that you put over your face. We also adapt physiologically, so somebody who's chronically living in an environment, say like Denver, they end up having a little bit faster respiratory rate than they do at sea level. They develop far more collateral circulation. They have some shift in the oxyhemoglobin curve, and they do develop some polycythemia secondary to that. That's adaptable. That adapting, though, does take time to get to. So immediately upon going to the higher altitude, you don't have those changes, but over the span of a few months, you end up changing it. For every mile that you go up, a good number to remember, for every mile you go up, you fall about 120 millimeters of mercury of barometric pressure. So if I were to look at Leadville, which is 2 miles above sea level, 2 miles means that there's a 240 millimeter mercury decline from sea level being 760, then the expected barometric pressure is 520. If I look at room air, that means that the atmospheric PO2 is just over 100, which means that you're going to probably have a situation where they're having a low PaO2 just simply because of water vapor and CO2 and all the other things in the alveolar air equation. So really what we're looking here is with the blood gases trying to get information about the 3 physiological processes that are important: alveolar ventilation, acid-base balance, and oxygenation. And I think last time I gave you a packet of talking about these formulas and how important they are to clinical management. PCO2 is what we're going to be utilizing to evaluate alveolar ventilation. Okay? CO2 production, alveolar ventilation, and PaCO2. That's how the PaCO2 is derived. Henderson-Hasselbalch Equation is basically what we utilize to evaluate acid-base balance. Again, you'll never have to calculate it, but it is something that we have to take into account. And then the other 3 all factor in for oxygenation: the alveolar air equation, the derivation of the oxygen content, and then with the oxygen content, the cardiac output, oxygen delivery. Let's talk about PCO2 and alveolar minute ventilation. I know it probably shows up better on yours than it does on the screen there. But if you look at it, we typically would end up writing the alveolar minute ventilation in this fashion. Right? But this is another way to think of it, that some component of that total minute ventilation is present is going to the alveolus, but there's also some that is wasted as far as dead space. Notice the dots. So I can, if I were to multiply this times this, that's where this would come in. So as CO2 production changes, that means that alveolar minute ventilation has to change also. We know that at rest, the amount of carbon dioxide that is excreted by the lungs is equal to the amount that is produced by anaerobic metabolism, and it's about 200 milliliters per minute. If I go ahead and plug that into my PCO2 equation, I find my CO2 production of 200, my alveolar minute ventilation of a little over 4 liters per minute, and then multiplying the numerator by 0.863 because I have different units that'll put the units into millimeters of mercury. and you could go ahead and derive it as normal PCO2. If CO2 production doubles, let's say you got a fever that's going on, or you got a high metabolic activity that's going on for some reason, that means that your minute ventilation has to double also. If not, that PCO2 is not going to remain normal. So a COPD patient who ends up developing a pneumonia, that pneumonia is going to cause a fever. That fever increases the CO2 production, but they don't have the ability to increase the alveolar ventilation. So let's say the CO2 production doubled. They can only increase their alveolar minute ventilation by, let's say, 1.5. Well, that means their PCO2 is going to rise. The numerator goes up, but the denominator does not go up proportionally. The value that you're measuring on the opposite side of that equation, in other words, PCO2, is going to become elevated. That's why patients with COPD who develop a pneumonia end up becoming hypercarbic and needing mechanical ventilation. It's a simple physiological, mathematical process that goes on. Does that make sense? You guys lie very well. Henderson-Hasselbalch Equation. Remember, the whole thing centers around a 20-to-1 relationship between bicarbonate and carbonic acid. So bicarbonate, which is in the numerator, carbonic acid, which is represented by PCO2 times the value 0.03. Again, that's how it puts that PCO2 in millimeters of mercury into milliequivalents per liter. That 24 to 1.2 yields a 20-to-1 ratio. At a normal pH, you'll end up having that 20-to-1 ratio. If you have the numerator getting larger than 20-to-1, or if the value is greater than 20-to-1, then I have an alkalemia. If it's less than 20-to-1, I have an acidemia as present. And since nobody has the log function on their calculator, we can't calculate this out. But I do. And the pK there, if you remember back, pK relates to, for various acid-base systems, it's a constant that is there, and I believe it's 6.1 or 6.3 for the carbonic acid bicarbonate buffering system. Okay, alveolar minute ventilation, or I'm sorry, alveolar air equation. We do the simplified version of it, where I end up having the barometric pressure less 47 multiplied by the FiO2. Remembering that this 0.8 that is there is not a constant. It's actually representative of the respiratory quotient, the relationship between the CO2 produced and the O2 consumed. Remember I said a long time ago, it's 0.8? That's going to change. Because I'm going to give you scenarios where I give you alveolar, give you the O2 consumption, CO2 production, and you calculate the RQ out. Plug it in and use it. That's the normal. But what happens if I have a patient who's hypermetabolic, producing more CO2, consuming more O2? That's going to affect this equation. It's going to affect the amount of oxygen that can be put into the alveolus. And we know that the alveolar value normally is somewhere just over 100. If I put somebody on 100% oxygen, there's no reason that it couldn't be significantly higher. If I were to put any of you on 100% oxygen, sit there for 30 minutes, and you were stupid enough to let me do a blood gas on you, I'll bet you your PO2 is going to be like 620. And we know that their water vapor pressure, we use 47, but there's a little bit of a, your author has a little bit of a different value there, 46.6. It's academic. Rise in PCO2 will tie up some of the space within the alveolus, the alveolar air equation that we show. As the CO2 gets larger, the ability to have oxygen there goes down. So hypoventilation is one of the causes of hypoxemia simply because it affects the alveolar air equation. Oxygen content or other measurement of Oxygenation takes into account not only the PaO2, but also takes into account the saturation and the actual hemoglobin present. That formula should be relatively familiar to you. Most of the oxygen that's carried is carried as oxyhemoglobin. The dissolved component does not contribute to the oxygen content. However, it does derive or does push what the saturation can end up being, 40, 50, 60, 70, 80, 90. So we have about 20 volumes percent as the normal arterial oxygen content. And we know that that term volume percent means milliliters of oxygen per 100 milliliters of blood. If I then multiply that oxygen content by the cardiac output, we end up with oxygen delivery, which is normally about 1,000. Where the oxygen consumption normally is about 250, oxygen delivery is normally about 1,000. So you end up having a great amount of reserve present so that as something bad happens, we can survive without having to go anaerobic. Lots of factors that can affect the oxygen delivery to the tissues. You break that formula apart. These are all factors. So something other than oxyhemoglobin, so you got carboxyhemoglobin, say you got methemoglobin, those are all types of hypoxia that can develop. Anemia, just simply from a reduced amount of hemoglobin, can make a difference. Hypoxemic hypoxia, boy, that sounds familiar. Remember my train? Thomas the Tank Engine? They're all factors that are affected. Cardiac output can cause circulatory hypoxia by a reduction in either stroke volume or a reduction in heart rate. Bada bing, bada bong. So, when we look at a blood gas, it means more than just simply classifying it into an acid base and oxygenation status. We want to go dig a little bit deeper, and that's the purpose of this course. We look at acid base to look at the metabolic and the respiratory component. FiO2 doesn't change, but barometric pressure does, secondary to Dalton's law. And we didn't talk about age, but age will also play a part also, because as you become elder, as you age, you actually lose functioning amounts of alveoli. Your FEV1 actually becomes reduced over time. Airway pressure is equal to barometric pressure. That's just common going back to how we breathe. We talked about the three areas of information, both clinical, patient assessment, as well as environmental. And there's multiple things that can affect oxygen delivery: saturation, hemoglobin, PaO2, stroke volume, heart rate. We know which ones are measured and which ones are derived, and we know about those wonderful equations.
International Express freight shipment for Siberia?
DHL can take almost anything to just about anywhere.
A little bit proud of himself. All right, 70-year-old female in Denver arrives in the emergency room complaining of dyspnea. She's placed on 2 liters nasal cannula. A few minutes later, you arrive to perform an ABG. Here's your results. What do we think? Okay. So respiratory alkalosis here. There's probably something else going on. Did we wait a long enough time to get the gas? That's part of the problem. I can't really assess whether that 62 is good or bad unless I know how long she's been on that oxygen. And if she's in Denver, that may be normal for her. She may be short of breath, complaining for some other reason involved. So we probably should repeat the blood gas after allowing the time for the oxygenation status to get it out. We get a second sample after 45 minutes, and we end up seeing that indeed PO2 is 60. We still have that respiratory alkalosis present. What other information would you want to know? Was there any other kind of disease that's present? Okay, what else? What's her respiratory rate? What's her heart rate? So we need to do basically, again, a bigger assessment of this patient. We have to get out of the comfort level of just looking at the blood gas and knowing everything to taking bigger pictures of that case. 27-year-old woman arrives in the ED comatose with a respiratory rate of 8. There's your blood gases. Okay. What other information would you want to know? I'm sorry? 27?
Why she come in comatose?
Why'd she come in comatose? Why is she breathing a rate of 8? Why was there a bottle of Jack Daniels and Quaaludes next to the bedside? Okay, so those are other information that's going to make this evaluation a little bit more challenging. And again, we could go back, looking at that 69 PCO2, predicting what the pH would be, predicting what the bicarb level would be, and going and doing a deeper analysis of it. Okay. Anything going on from clinical? All right.